Hello, everybody. Welcome. Uh, Gosh, yes, I got it. Thank you very much. Um, Welcome to our new series of talks for this semester. This is the first time we're trying a panel. We'll see how it works. So I'm delighted to welcome my colleagues, Roald and Claire. I'm going to start off with a brief introduction, and then Roald, and then Claire, and we're each going to talk for about 15 minutes. And Eileen will help us keep on time, and then we'll have 15 minutes for questions and discussion at the end. This is a very interesting topic. I wanted to say a little bit by way of introduction. I'm Fred Volkmar. I'm at Southern Connecticut State University, but also at Yale. I've been in the field for a very long time now, and I've had a very strong interest in diagnosis and issues more recently in aspects of cultural diagnosis, gender, and other factors that might impede diagnosis in some groups. And now, but by way of background, since the very beginning, boys have been seen as more commonly affected with autism than girls. This was true for Connor, who saw 8 males and 3 females, but he saw some. Asperger's description was of boys only. Subsequent work has confirmed a higher male-female ratio, typically in samples 3 to 5 to 1. Claire may have something to say about that with her data. In general, females have often seemed to be more severely cognitively impaired. The whole question of what it means to be more or less severe is a complicated question I'm sure will come up. Among them more higher cognitively functioning, the rate is more like 25 to 1, in some studies as high as 50 to 1, male to female, depending on how high you are going in the IQ range. There was much early confusion about autism, as people know. In the 1970s, several things converged to make it really clear that autism was a disorder in its own right. It was not a form of childhood schizophrenia. It was a brain-based disorder, given the high rates of seizures. It was very strongly genetic, and it responded best to structured treatment. As a result, autism was first recognized in the DSM-3 in 1980 in its own right. There it was defined as infantile autism, and there was an odd category called residual infantile autism for people who had once met the criteria for infantile autism, but no longer did so. This was their attempt to deal with developmental change, which was not very satisfactory at all. Early awareness of gender differences, and there was some interaction with genetic factors. There was clearly some awareness early on about the problem of lower rates in females. And some of the question was, well, maybe it takes a bigger genetic hit to cause autism in females, and that might account for both the lower rate, but also the fact that in general, females seem to be more cognitively impaired. However, there was a real lack of appreciation of factors that might bias the data for females. Issues of differences in syndrome expression and things like affective awareness in females, greater potential for a diagnostic camouflage that might lead to later diagnosis, and greater potential for diagnostic bias. Most importantly, I should note, females often were excluded from research studies, and this is a problem. As people know, there are both categorical and dimensional diagnoses. The categorical diagnosis is the DSM, which has evolved from 3 to 3R to 4 to 5. It has its own complexities and complications. Dimensional approaches include things like the ADOS, the CARS, the SRS. All these things are based on either a combination of observation intervention, sometimes on self-report, or sometimes on parent or teacher report. As we're going to hear, I think when Roald talks, there are some issues about these. There's no specific biomarkers yet available for autism, although some things are in the works. So what do we know about gender differences in autism? Well, actually, there's a number of studies, and I'll have these as a reference in the last slide that people can see. It's interesting. It looks like, according to at least one study, that females with ASD require more symptom severity, but they were also more likely to exhibit internalizing behavior than boys, and they may be better at camouflaging. All these may be things that tend to disguise the diagnosis. They also seem to be less likely to engage in repetitive behaviors. Boys are more likely to be externalizing in terms of their behavior problems. Girls may have better joint attention, had better social skills, and less disruptive behaviors. So all these things may complicate the issues of both screening and diagnostic criteria. And this is something that we've just recently looked into. And Roald is, I think, going to talk about some of the Norwegian data. But the bottom line is that there's been probably a systematic, unintended, but systematic bias against the diagnosis in females, especially more cognitively able females. More gender issues. We know that most of the dimensional instruments work less well for the more cognitively able. And so keep in mind that this is where the instruments came from. The instruments, the dimensional instruments mostly came from work with boys of school age, of early school age, with mild to borderline intellectual disability. So not surprisingly, they don't work less well at either extreme, and they probably don't work so well for girls, especially higher functioning girls. So they may be systematically missed. As we're going to hear, there's some systematic problems with screening and diagnostic instruments, and we're now aware of the potential for girls to more ably camouflage in reality and come to diagnosis much later. And I want to give a quick case example, if I can. So this is just a quick example. We had a 10-year-old girl who was from Texas, and she was doing block design, as people will know from the Wechsler. And she saw the red triangle and on some aspect of the block design, and she comes out and says, "This is a Ventnor." Now, I should say that this is a girl who was coming for a question of did she have Asperger's, but her special interests had not been horribly intrusive during the testing section. You know, many times when you see children with the diagnosis formerly known as Asperger's, their special interests are so intrusive, it doesn't matter what you show them, they will talk about their special interest. But this girl was minimally, you know, she didn't talk much about things that she was interested in, but she did say, "This is a Ventnor." The psychology trainee who was doing the test was so intent on getting the test done that she didn't ask her. And after the break, when I had a chance to talk with the trainee, and I said, you know, go back in and ask her what a Ventnor was. It's interesting. All of a sudden, we discovered what a Ventnor is, and some of you may know. A Ventnor is a kind of cow, and being from Texas, and she pulls out the trainee talks to the little girl and says, "Oh, what's a Ventnor?" And the little girl goes to her backpack and pulls out her book of cows. And she talks about how the Ventnor often has, as you may see, a triangular shaped black marking on its side. And she's like, "Oh, that's a Ventnor." And that gets her off and talking about her interests. So this is just an example of how she has a special interest, not horribly intrusive. And it certainly didn't dominate her life to quite the same degree that Asperger talked about, but it was very much there and not too far below the surface if you ask about it, but you had to know to ask about it. Whoops, sorry, back here. So by way of a quick summary of the instruments and the discussion, there's been much progress since the 1940s, a growing body of research, but there's been a real problem with understanding the boundaries of the autism spectrum disorder condition. Is it a broad or a narrowly defined condition? The DSM-5 would say rather narrow. The genetics and much of the research on family members would argue for broad. The gender issues seems to be a major underappreciated variable and problem, both in terms of screening and diagnostic instruments, and maybe for that matter, even in terms of diagnostic criteria. This is a real problem for people coming to late diagnosis. It comes both as a clinical and a research problem. And given the fact that often females were excluded very early on from work on autism, our knowledge is actually comparatively much more limited than it is for males. Clearly, as we start to get biomarkers and more specific issues that are gender related in terms of biological biomarkers, we'll do a better job of diagnosis. But at the moment, we're still somewhat struggling upstream to try to sort this whole mess out. And here are some references. Oh, I'm doing really well in terms of time. I'm so proud of myself. Here are some of the references I mentioned. And in just 1 second, take a screenshot if you want to copy these references. And this is a selected list. But in about 10 seconds, I'm going to turn things over to Roald, who's going to be talking about, I think, some of the data from the screening instruments in Norway. Okay.
Thank you, Fred.
Now, can we get Roald up? Can I go away?
I can stop yours by.
Good, thank you.
Hang on. Let me just see here. I have to see if I get to share my screen. There is always something technical. Can you see my screen now? Good morning, everyone. My name is Roald, like in Roald Dahl, the author of Charlie and the Chocolate Factory. I'm a professor of developmental psychology at UIT, the Arctic University of Norway. And I'm also an adjunct assistant professor at the Yale Child Study Center. I've been mentored by Fred for nearly 8 years, I think. Time flies. And I'm also a father of a girl with autism, which kind of led me into this field. And I was talk a bit about the complexities that we have associated with gender or sex in terms of the diagnostic or the screening process and the diagnostic process. So there are some challenges first that Fred quickly mentioned, and that's kind of the prevalence is probably one of the biggest challenges we have. We're kind of in an increase of prevalence of autism more general, but the biggest gender difference that we know of is actually the male to female ratio. And it's kind of skewed since the seminal studies of Kenner and Asperger, as Fred explained. And I think that one of the big problems today, we are actually, one of the reasons we are kind of paddling upstream is that for many years, for 40, 50 years, we have developed criteria and we have developed kind of standards for autism diagnosis that is based on predominantly male cases and studies. So that's one of the challenges we have. The latest number of a male to female ratio is like 3.1 to 1. But we know that if we look in different groups, like Fred said, in the more cognitive able group, there is even less females per male. But if we look at those who have intellectual disability, this male to female ratio seem to be closer to 2 to 1 or 1 to 1 actually. On overall, we think about it as Fred said, studies show between 3 to 5 per girl per male, and that's quite maybe the most consistent finding in terms of gender differences. It's like Fred said, we know that females are more oriented towards social stimuli. We know that males tend to score higher on externalizing behavior. That might actually be one of the things that might cause concern for parents and professionals is when we see that males have more of these behavioral issues and externalizing behaviors than females. We also know from different studies that when females have complex phrases in their verbal language, they're also in the cognitive able group, the Asperger group, they're identified much later. I think the numbers are quite like 9.5 years compared to boys where are like around 7 years. And then we also have the issue that we have lower levels of repetitive and restricted behaviors in females that is found throughout studies. And the challenge is with this is that if we have females have less externalizing behaviors, we might tend to not have the same concern as early as we do with boys. We have studies, but most studies have small samples of females, so that's also a challenge for the future. There is also this nature about camouflaging, where females are more or better at camouflaging their symptoms, and behaving appropriately in a social context by learning the behaviors needed to camouflage their symptoms. And then it's also interesting that, which Fred also mentioned, is that like that case he just described, it's that something me and Claire just spoke about the other day, is the fact that what we see often in boys is, for example, special interests that are quite uncommon, or not something that you would expect from a boy at a given age. But with females, we tend to see more often that these interests are more typical, but they are more extreme. Just the other day, I saw this dating on the spectrum on Netflix, and I saw this adult woman that was collecting Barbie dolls and so on, to a great extent. That was kind of, it's not the normal with Barbie dolls when you're 6, 7, but collecting them when you get older, and to that extent might not be typical. So there are a lot of challenges here that we need to kind of pick together. We also know that females within the normal range IQ scores better than their male peers on the ADAS, and I will talk quickly about that afterwards. I want to take a look at the studies we have done, and we have kind of looked at the MCHAT, which is, I don't know if everyone knows what MCHAT is, but it's the modified checklist for autism in toddlers. It's the most widely used screening instrument. It's not very good at identifying kids with autism in the general population. However, I won't go into the problems with screening, but we actually used the checklist to see if we found differences between males and females. And what interestingly we found was that when we looked at typically developed kids at 18 months, males had a higher score on the MCHAT than females, indicating probably that females at 18 months are more developed than boys at 18 months. Not much, but there was still a difference there. When we looked at the ASD group, we saw that the females scored significantly higher on the MCHAT than the boys did. And that indicates some kind of higher symptom severity at 18 months of age in females compared to males. And that we can kind of like, that is in line with some of the literature that kind of indicates that if you are to be detected at 18 months, identified by a screening instrument or a diagnostic instrument at 18 months, you might need to have a higher degree of severity if you're a girl to be identified at that age. However, when we looked at the whole MCHAT and the different items, we saw that females had a strength in joint attention over males. And that's also in line with most research we know. We know that females with autism are more likely to have better joint attention skills. What we also found, and that's not as strong as that finding, but we found that females less often had the ability to imitate this social smiles from their parents or caregivers. So that's a weakness in imitation, which imitation is known to be kind of a weakness for all kids with ASD. So this kind of was the first paper we did and the first research finding we had. And then we kind of like went further and we looked at, okay, so if we look at these modified checklists for autism, we know that that actually misses the identification of most individuals with autism at 18 months. So we decided, so let's look at those kids who were not detected by the MCHAT at 18 months. So that's kids that didn't raise any flags with parents at 18 months. And we tried to tell us what are we actually looking for in them in terms of gender differences. And these are children that later are identified with an autism diagnosis, but did not have any concern at 18 months. And if we looked at the developmental milestones, we saw that these children that had a negative score on the MCHAT not like being at concern, but receiving a diagnosis later, they had some atypicalities in their developmental milestones. For example, they were not as good as the typically developed children on all these different subscales, both socially, communication-wise, and motor skills. And that was the same for both boys and girls, but girls were more pronounced, had more pronounced difficulties on the motor domain than the boys compared to their peer typical developed individuals. What we found really interesting is when we looked at these temperamental features at 18 months, it's kind of indicated that the most interesting finding, or the only finding that I'm going to highlight, is actually that we found that those girls with autism at 18 months, they were less fearful of social situations than both boys with autism, but also girls and boys without autism. And that's interesting because when we started looking into the items that kind of comprise this scale, shyness scale, which show that females with autism had less shyness, we kind of saw that the items that were driving the whole scale was actually related to the warm-up time to a stranger, and probably items that are connected to social inhibition, which is relying on cognitive components to actually have the social inhibition. So that might also indicate that the females have some cognitive issues at 18 months that might affect their social inhibition. So we, like for both boys and girls, we see atypicalities in developmental milestones. They are slightly different. It's not the biggest findings. It's fairly few findings in differences on just these items. And I think that when we look at the bigger picture, I think me and Claire also discussed that the other day. It's the fact that most of the findings we find between males and females are nuanced. And if you have created criteria that detects mostly boys and girls, some fewer girls, it might be that those girls who are detected look more male-like in autism symptoms. And when we, before I let Claire come to the word, we did a study just recently where we looked at individuals from Seattle Children's Hospital and Children's National, this GENDAR consortium study. And we looked at individuals between 8 and 17 years of age that had within normal range IQ. And what we found is interesting here is that on the ADAS scores, which ADAS is one of the gold standard diagnostic instruments, we found that the females more generally scored better on all the pro-social items and subscales of the ADAS. And that indicates that in a clinical setting, females might seem to be better in social situations and in terms of social behavior. On the other hand, it also kind of highlights that if we rely too much on the ADAS, it might also result in underdiagnosis for females, and that this diagnostic tool likely contributes to a prevalence difference between males and females. One of the questions that I often get when I present this paper with it is that, so should we change the algorithms on the on the ADAS to have one algorithm for girls and one for boys? And I think that that's a very complex question because then we're talking about not meeting criteria versus meeting criteria or threshold for a diagnosis. Quickly before we finish up, we have made it like a theoretical model of the ASD identification in females, and that's kind of based on some points that we know that if you have, like, if a girl has better joint attention, as we know females often have, we also found that they have less oversensitivity and this is on a group level, not on an individual level. We also see this less social fearfulness or better like lack of social inhibition. And we also know from various studies that they have less repetitive or restricted behaviors. It might not even be that they have less restricted repetitive behaviors, but they are different than those we see in boys. So we have a harder time of identifying these girls due to symptoms not being decreased, but so different that we kind of not pay attention to them in the same way as we do with boys. Given we have all these strengths in girls, if we remove the severity and language difficulties, indicating cognitive able girls, it might actually indicate that due to the strengths they have, they will not meet the threshold for diagnosis or criteria in the ADAS or screening instruments. And that's kind of a challenge. And then the question is, should we change the algorithm of different measures? And I think that's a bigger discussion we can probably answer later on. I will leave the word to Claire end on that note.
Well, thank you. I will get my screen up. Can you see my notes or the full screen?
No notes, full screen.
Right. Okay. So my name is Claire Harrop. I'm an assistant professor at UNC Chapel Hill. I'm a developmental psychologist by training. I'm from the UK, but have been out in the States for a long time now. I also have an appointment with the UNC Teach Autism program, which is where all the data that I'm presenting on today comes from. So I'm going to kind of scale up and take a bigger view and be less in the weeds of specific behaviors and look at statewide trends. So we're looking at 20 years of data from our UNC Teach clinics. So I just want to start that I do receive occasional training and speaking fees, and I have funding from the NIH and a few foundations. And the work presented here was funded through a CTSA Career Development Award and through our IDDRC at UNC. So the overview of what I'm going to talk about today, a lot of the groundwork has been done for me, which is really nice. I'm going to give an overview of sex differences. I'm going to talk quite a bit about what UNC Teach is and this data. This is messy data. This is data that was not really intended for research purposes. It's from our clinics. So it's a very different approach to a lot of my other work. My work prior to this was kind of a COVID shift, actually. My work has been in well-characterized samples of girls using eye tracking, behavioral measures, EEG. We have a longitudinal study that was just funded. But this work was really driven by the fact that in 2020, everything stopped. And I had a career development grant, and I had to do something. So we started digging into these databases, as well as some others that I was connected with. So as we know, autism is a male-dominant condition. And I always say that actually this is probably one of the most replicated, if not the most replicated finding in autism research, that we see more boys compared to girls. But there is a lot of debate about the sex ratio, as we've heard, whether this is closer to 3 to 1 or even less than that. We know that the ratio of males to females really does vary based on severity of symptoms and whether individuals have co-occurring ID. So we think girls and boys who have co-occurring ID and language delay, the ratio is closer to 2 to 1, maybe even 1 to 1. When we go to the higher end, what we previously thought of as Asperger's, it can be anywhere from 8 to 1 to 12 to 1. So it's a much bigger range. We know that females are diagnosed later, and they often need other factors to get them through the door. So these are these externalizing behaviors that Fred referred to. We also know that the number of late diagnosed individuals, particularly females, is increasing over time. And I saw a comment in the chat about kind of later. I don't have a good answer as to what late diagnosis is, and I can tell you what we did in this data set. And we also know in the general population from large population-based studies, one out of the UK called the ALSPAC study, that in the general population, autistic traits increase with age, particularly for females. So when I'm talking about females here, I'm talking about females that were assigned female at birth. So what we did in this study, and parts of this have been submitted for publication, is that we utilized a standardized and comprehensive statewide database, which spans 20 years of diagnostic evaluations performed at our teach clinics. And we had 4 questions, which was, are more females being diagnosed over time? Has the age of diagnosis lowered for females over time? Do we see an increase in late diagnosed females? And has the profile of females changed? So this data is drawn from our UNC Teach clinics. For those of you who are not familiar with UNC Teach, we have been operating predominantly out of, well, we started off in the Chapel Hill area, which is where I am, in the 70s. And we have grown and we serve the whole of North Carolina. So now we have 7 clinics and we see individuals from all 100 counties in North Carolina. And we conduct diagnostic evaluations and we also do treatment. The great thing about Teach is that it spans all of our states. So the Asheville area over in Western North Carolina is very rural compared to Raleigh, Charlotte, Greensboro, Chapel Hill is more urban. And I say that as I used to live in LA. So I'm going to say urban as a quote unquote. It's not huge. They're not huge cities. But we do see, as the demographics of North Carolina have changed, we typically reflect those in our Teach clinics. Until the mid-2000s, we were actually a free service. So anyone coming in for an evaluation, it was free. We shifted to take insurance, and about half of our sample are Medicaid, and we are in network for pretty much all the major insurers in North Carolina. I will say not with Duke, but we are for most of like Blue Cross Blue Shield and a lot of the other big networks. Participants were included in our database if they were evaluated and diagnosed with an autistic disorder based on the DSM criteria in place at the time of the evaluation, and if they consented to have their data put in this database for research purposes. So actually, the UNC Teach database is the longest living IRB at UNC. That's how long it's been going. Now, some of the data in that, going back and looking at it is quite challenging. So we used 20 years of data. We used data from January 2020 to September 2021 to look at this. So we looked at a kind of a 20-year chunk. So this is our sample. We have around 10,000 individuals, and the ratio is what we'd expect. We have around 81% of these are males and just under 19% are females. About 2/3 of the sample are white. I will say anyone who's worked with state level data, clinic, school data, it's messy. And as the person who dug through this data, you'll see that we have over 2/3 of our ethnicity data missing for this. We can infer based on census records what the ethnicity of our sample was, but it just wasn't collected before a certain point. And this is just the nature of working with this kind of data. So to analyze this data, we broke the sample into 4 age bands. We are actually going back and looking at age as a continuous variable, but for the purpose of today, I'm going to talk about these 4 brackets. So we have 2000 to 2005, which was about 2,500 individuals, 2006 to 2010, which was about 3,500 individuals, 2011 to 2005, which was just over 2,000, and then 2016 to 2021, which was about 1,700. We obviously saw a drop in the number of evaluations in 2020 and 2021 due to COVID restrictions. So the variables we were interested in were year of official diagnosis, which we grouped. If you're a recent reviewer for me, you didn't like that approach, and we're going back and looking at it continuously. But for the purpose of today and for clarity, I'm going to do the chunks. Age of official diagnosis, and this was really calculated by date of birth and date of the diagnostic evaluation. As I mentioned, this is messy data. I was the person going in and kind of looking at this. We had some kids that were diagnosed at 2 months or before they were even born. So then we're combing through this data set for things that just aren't, one, just not possible, or they just don't look like they're possible. And we're trying to go back to the original source as much as possible, but it's really challenging. So we did have to exclude a number of cases. And the table previously with the 10,000 in, they are the cases that we combed through to make sure they looked correct. We used the childhood autism rating scale for autism symptomatology, and for cognitive ability, it was kind of a smorgasbord of whatever we had. So we had the Mullen, the Merrill-Palmer, the LIDA, the WISC, or the WAS. Out of those 10,000 cases, not all of them had this data. So I think that's important. About 2/3 of the 10,000 had IQ data, but only about 1/3 had CARS data. So what did we find? So are more females being identified over time? And what we see here is we do see our pink, and I'm typically pretty gendered in my graphs because I think it's easy, but sometimes I like to mess with people's minds and switch the colors around. But here, pink is girls. We do see that our girls increase over time. So the proportion of females receiving a clinical diagnosis in North Carolina, the proportion of males to females decreases, and that is the percentage of females is increasing. And it goes from around 15% in our earliest bracket to around 20, just under 25% in our most recent age bracket, representing nearly a 10% increase. And this change was significant. What about the age of diagnosis? Well, this is where the person who spent pretty much my whole career working with females, this was an interesting result to digest. The age for females in the whole sample was higher. So across the whole sample, it was around 9.5 years for females compared to around 7.5 for boys. But there was an interaction between time and sex. So we actually found that girls were getting older in later time points. So we weren't seeing the age of diagnosis going down. The age of diagnosis for females was going up, whereas the age of diagnosis for males was staying pretty standard. So in our earliest time period, girls were just over 8, and then they were rising to around 11 years and 3 months in our most recent time bracket. So are the number of late diagnosed females increasing? So this is females that are getting diagnosed outside of childhood. And this does create a nuance for us because the DSM criteria states that behaviors and challenges must be present in early childhood. But we are seeing a number of individuals being diagnosed in adolescence and adulthood. We picked the age of 13 to split our group. There was some rationale in this, but there are other papers that use 18 as late diagnosed / adult diagnosed, and you can kind of cut the data different ways. You could do it at age 10, or we selected age 13. So across the whole data set, around 15% received what we termed a late diagnosis. And this was more common in females, increasing over time, which is what we'd expect based on the age of diagnosis going up as well. So finally, has the profile of autistic females changed? So what we saw in our later time bracket was that females had decreased CARS scores. So they had lower autism symptomatology and they had higher IQ scores. Prior to 2016, they did not differ. So this is interesting for us. The girls that are coming in later dates seem to look different, which is, I think, what we're observing in a lot of clinics. So what are our take homes? So the proportion of females diagnosed at statewide centers has steadily increased over time. We think this is potentially due to greater societal knowledge about how autism manifests in females. We do see more of a push from our leadership at our teach clinics, and also just in society, we know more. We see we see an increase in the number of females diagnosed in adolescence and adulthood. And at first we thought, well, is this something specific to teach? You know, we do have a big focus on adolescence and transition to adulthood. Is this something unique to our work that we're doing? But actually in a UK-based study, they found a similar, they mirrored these trends. So they also found that females were increasing in their diagnosis, typically in adolescence. So this seems to be reflected in both US and UK data. Females receiving their diagnosis later in our sample seem to have lower autism symptomatology and higher cognitive ability. Again, something that has been seen in previous studies on a smaller scale. So this suggests that the profile of individuals getting diagnosed in later years is changing. So there are a few limitations. We use the CARS scores over the ADOS because we had more CARS data, so that's what we went for. We had fewer evaluations due to COVID. We really wanted to look at verbal IQ, but we just didn't have the breakdown. As I mentioned, anyone who works in school or clinic systems, just what goes into a database can look it isn't a research database. It isn't set up for these purposes. And we're missing a lot of ethnicity data. We're in the process of exploring the data, particularly to look at co-occurring diagnosis. ADHD, for example, there's a handful of studies that have shown that females were likely to, if they already had an ADHD diagnosis, this delayed their autism diagnosis more for females than for males. We know that females are more likely to be misdiagnosed and drop their other diagnoses when they receive their autism one. We're looking at the impact of different DSM versions and what the referral source was. Did people come from, do we see an increase in self-referrals is the thing that we're trying to drive. So I just want to thank you all for listening, and here is our lovely Teach team, and of course thanking all our Teach family. I will stop sharing my screen.
Thank you so much. If anybody has any questions, you can write them into the chat. I do see that Roel was also answering the later question. I was considering up to 14 years of age is considered later.
Yeah, I think that's something that we're struggling with because it's defined differently by different studies and different groups. There doesn't seem to be any consistent terminology for what late diagnosis is, and I think that's a challenge.
I also think that the findings that Claire has that are mirrored in the UK data is clinically, it's mirrored in the Norwegian data also. It tends to be more girls tend to be identified, and they are later identified. And one of the biggest issues we meet, like when I work in a clinic with primarily girls above the age of 18, because at the age of 18, they are referred to, there is a split in between the child, adolescent, and adult clinics at 18. And so I see mostly girls around 18. And what's really difficult is one point that Claire identifies is that it should be some symptoms there early in the developmental period. And what we have seen a lot is that we have both girls that have been in the child and adolescent psychiatry department with social anxiety for many years, and now they're coming in for a new assessment for autism. And there is a distinct difference between groups that are referred as adults to us. And that's some of these girls, when we go back and we talk with their teachers and kindergarten teachers, it's exceptionally how much teachers remember about kids. Even if it's like 15 years ago, they remember them. And what we have found out that it's kind of a distinction between those who were quiet or a bit reserved when they were younger. They didn't have many like friends when they were a child. And then we have those who have social anxiety and then wants a referral or a assessment of ASD. And when we go back, we see that they were actually the leader of the gang when they were in elementary school, and they didn't have any of these difficulties that we associate with autism earlier. And that's kind of makes it a kind of a decision. That's where we make the decision. So if we don't see any of these signs early on, and there is no other indication of autism, but social anxiety, more of an emotional disorder, it's a good way of this, like making the distinction between autism or not autism in these girls, because social anxiety and autism might look a lot like when you come up in the 20s. The other thing when Claire mentioned is the ADHD, and what's interesting is that when we see on the numbers of ADHD in Norway, and we look at Tourette's, other neurodevelopmental disorders, the ratio between 20 and 30 years of age are 1-to-1. But before that, it's 5-to-1. So the question is it the same for autism? We don't have studies indicating that yet, but it will be interesting to see.
Yeah, and just to complicate life a little further, and it's not quite on the issue of gender, but it is on the issue of late diagnosis. My former trainee, Susan White, who's now at Alabama, when she was at, I think it was in Virginia, at Virginia Tech, and she got saddled with the wonderful opportunity / burden of teaching Psych 101, and gave everybody, 400 students in this class, 2 screeners, one more of a categorical and one more dimensional. I forget whether the one was the ASQ and the other one I'm pretty sure was the SRS. Anyway, between 0.5 and 1% of her class, none of whom had a previous diagnosis of autism, checked positive. And so there is this general problem of people who appear to make it on the screeners that are reasonable enough screeners, but then don't. And she followed up then with interviews of these handful of students. But that's sort of a whole nother problem. And as Claire alluded to, there is some suggestion that perhaps maybe girls, quote unquote, grow more into autism, as it were, as they get a little older. So it's a very interesting area indeed to get into. And it's one, I worry about at the level of things like the DSM. The DSM, as you know, at the moment, Jonah has swallowed the whale with the DSM. The DSM is basically a kind of a redo of the ADOS and the ADI in a sort of somewhat slimmed down version. So the problem is if there's a bias in instruments like the ADOS or the ADI, which there might well be, that's going to then be reflected in the diagnostic criteria, which is a real worry. And it's something I think then as it just perpetuates itself as time goes on.
Yeah,
it's a real problem.
And there was a recent study, and I haven't dug into the weeds a bit, but I have briefly scanned it, that when we look at community referrals, these girls, when we put in the ADOS and the ADI to get them into research studies, we're losing them. And they call it the leaky pipeline. So we get pushback. So we have a newly funded longitudinal study, and we tried to be a little vague in our inclusion criteria. And we're like, we're just going to go on best estimate clinical diagnosis. That's fine. We want to get these girls in. And we got pushback from the reviewers and from our program officer, like, you need the ADOS and the ADI. And we're saying, well, we're not getting these girls if we do that. We're never going to be able to recruit 140 girls. I mean, it's just impossible. So they have allowed us to we're doing the ADOS we're doing the SRS, and then we're just doing a clinical judgment. We have clinicians in our team who will review everything. Cases that are borderline, they'll be there during the visit, and we've been able to take out the ADI, and we've been able to argue that, you know, we want to try and get more of these girls in, and regardless if they score a 6 on an ADOS versus a 7, really
Exactly.
it's a 1 point difference that determines whether someone's in a study or not.
And you know, Kathy Lord would be the first person to tell you these instruments. One of the problems is all the diagnostic instruments, and for that matter, the screeners, they really, in some historical, very clear historical, continuous sense, they rest back on the earliest screeners, which focused very much on school-age boys of mild to borderline ability. And that's kind of their intellectual history and where they come from. So it's, and mostly, my guess is a white sample. And so we're seeing issues within the US underdiagnosis in minority populations in some areas. I think there's some data that shows that in screening for some screening tests, Hispanic families score higher on things like the MCHAT than other. I mean, so there are these suggestions of cultural differences. And then when you move it outside of the US, all bets are off. You know, I can imagine that for the group of us, basically Scandinavia, UK, Canada, US, the English-speaking countries, Northern Europe, maybe Japan, it's more or less homologous. But you know, even Japan, there may be some issues around things like eye contact in terms of diagnostic features. And it's part of a more general problem of, do we have instruments, both diagnostic and our criteria, that are truly culture-free, gender-free of bias? And I think we have to question that. I think we can't just assume that it's a thing. And for sure, you can't just take an ADOS or an ADI and assume that's going to necessarily, you know, give you the final word. And that's a problem, because as we reify it, it's, as I say, it's the dog chasing its tail. We're just going to miss these cases.
Yeah, and I think that on the other hand, it's a very complicated question, because you have also the autism, the AQ from Simon Baron-Cohen, and we know that most individuals have like self-report, have an elevated autism trait score on the AQ. If you do that in the general population, you might get like 30% that has scored within the autism symptom area on the AQ, and so some of these self-report are maybe accelerating autism symptoms, while the ADAS, on the other hand, is maybe the opposite. We kind of miss them because they have a lower score. So I think that what we've done in Norway is that we have a very strong focus when we are training clinicians in the ADAS to let them also, a part of the training is that the ADAS should never be the result of the assessment, like the main decider for the assessment if it's autism or not. It's just a clinical guidance to actually, and one of the other problems, and I spoke with Claire, and it's like what you kind of told us, Fred, right now, that the ADAS, and Kathy has said this on numerous occasions, that the ADAS was initially created based on boys school age, mild to borderline intellectual disability. And doing some of these ADAS module 4 and module 3 with cognitive able both adolescents and adults can be very hard. It's very hard to kind of, especially when you have individuals within the normal range IQ, it becomes almost embarrassing to do them, because they are so simplified and they are probing in a way that is probably not normal for how you speak to a 25-year-old. So it's many difficulties in the diagnostic process, I think, that we need to kind of tap into. And it's, as Claire said, it's clinical judgment that is kind of the core component to look at in terms of what is autism in girls. And 6 a score below threshold on the ADAS, it still might be autism, and especially if it's a girl. So from the ADAS study we did, it might actually be that if you look at all the other items than the pro-social ones, and you kind of get a score that is lower because of pro-social behavior, it might still be interesting to look at it as probably autism. But the difficulty is always that what is late diagnosis also. I think Will Mandy in his paper has around 35 years of age, around there. So it's different from study to study. So,
and usually there's reasons, very interesting reasons for you see these people who come to diagnosis late, and there's often some complicated explanation, which in retrospect you understand, but it's, I've seen people, and certainly in their 20s, who come and for whatever reason, they just haven't needed a diagnosis. And in the US, usually you need a diagnosis, but for whatever reasons, their family circumstance, they didn't need one, so they didn't get one. And they don't have eligibility often for services. And then something happens and all of a sudden they do need one. And that's a very complicated business. And just to throw in, and I know we've only got a few minutes left, back to the ADOS and the ADI, I know because we were involved with Mike Rutter and Kathy in the early genetic studies. The ADOS and the ADI were originally developed so that around the world, as people were doing these genetic studies, we were all diagnosing autism the same way. So that was the goal. It was a research goal and a praiseworthy goal. I'm not knocking it at all whatsoever. We use the ADOS all the time. But the original goal had been more this research focus and not so much the clinical focus. And as a result, you didn't want people on the fence. You wanted people who were really clearly in the autism ballpark. And so that's another one of the kind of tensions that goes around using instruments like the ADOS and the AD, those that inspire the criteria, which then become reified versions of the ADOS and the ADI, and you have yourself a problem.
If I can just shoot in quickly, it's also interesting that during the COVID, we have seen an increase in all the neurodevelopmental disorders, and we have these social media TikTok versions of both autism and ADHD and Tourette's in girls that is becoming very stereotypical white girl with very stereotyped behavior. And I think it's we discussed this, Claire, and it's very interesting because in the clinic it's kind of different than what you see on social media and so on.
Claire, we'll give you the last word.
In the chat about biomarker research, and I know we're at time, so I don't know if anyone can do a 30-minute soundbite on biomarkers.
Well, there are some studies going on right now. There's some candidate things that people are looking at. People are doing some things with EEG and face processing. Jamie McPartland here at Yale has a big grant. It's a multi-site grant that's looking at that. There are others as well. And the FDA has gotten involved, which means it's going to be an even more complicated government process than usual. But looking at things that might be more like, in hearing testing in children. I sometimes joke that my wife is a pediatrician. How would you be satisfied if you walked in and said, "I'm worried my child is deaf," and the doctor gave you a 20-some item deaf checklist? And you say, no, I want a hearing test. And even now with newborn babies, we can do, auditory brainstem evoked responses. So we need something more like that. Whether we get something more like that, we're going to have to see. And given the diversity of autism, we don't know how well it'll work, but it's going to be interesting to see. And that may or may not help. We hope it helps.
Yeah, and I think obviously there's big NIH studies doing imaging and in EEG, and in my lab, we actually use eye tracking because I'm not a neuroscientist. I've dabbled and I'm not that smart. So I like eye tracking. I think it's very visual, and we found some nice differences that we then have tried to extend and to see whether that extends to neural processing with EEG with people that are more capable of EEG than me. So I think there's definitely work going on. There's also people reflecting on studies they've got, such as the IBIS network, the Infant Brain Imaging Study, which is based out of here at UNC. And their recent renewal of the ACE has a sex differences aim to go back and like kind of look at these siblings with regard, mostly with imaging is the data that they have.
So it's very interesting. So I appreciate everyone's joining us today. We will go on next month, and Eileen, who's there, can remind us who's our next speaker.
Our next speaker is Dr. Mark Woodbury-Smith. He's going to be talking about youth's risk of involvement with extremist groups. And registration is open, same registration link that we used for this presentation. And I've put up the schedule for the rest of the semester. We're still working on that in December.
And I want to thank our speakers. It was a great discussion, and we hope people enjoyed, and please give us your feedback. We could keep going on this topic for quite a while, I think. But thank you all very much, and have a great weekend. Goodbye, everybody.
Thank you.
Goodbye.
Thank you so much.
Bye. Thanks for organizing, Eileen.
Oh, no problem. Thank you guys for taking the time.
Well, it was great.
Yeah.
We could have spoken for 2 hours.
I was not going to ask, and Eileen, you may know, is